My name is Bruce Cree. I'm a professor of clinical neurology at the University of California, San Francisco. I would say there are a few things that are very important for understanding autoimmune disease. Clearly, the identification of autoantibodies that are pathogenic is extremely important. Understanding how those antibodies are pathogenic in many cases also extremely important. And so antibodies that fix complement and being able to inhibit complement fixation has been revolutionary in treatment of not only NMO, but myasthenia gravis, for example, among other conditions, of course. PNH was the start of all of this many years ago. But atypical hemolytic uremic syndrome and other, very difficult to treat and severe illness now is actually quite manageable in the inpatient service. So we've seen major advances in terms of complement inhibition. And as you point out, there are now these neonatal FC receptor antibodies that can downregulate antibody production very dramatically, and this can result in remarkable improvement in function in patients with myasthenia gravis and other conditions. So very exciting to see all of this work being done. And our understanding of how to manipulate the immune system, how to engage with it, different aspects of immunobiology, whether it be things such as B-cell depletion or specific interleukin receptor blockade or complement inhibition, et cetera. All of these things just have really added to the tools that we have in our armamentarium to address a wide variety of autoimmune conditions. And it's only going to get better and better. The development of CAR T treatments in autoimmune condition also in oncology, but that is going to have an unbelievable impact in autoimmune biology if the preliminary data winds up being true. And of course it's unblinded data and all the caveats there, small n. But if that work winds up breeding true in randomized controlled trials that are well conducted and carefully, adjudicated, this is going to be something that absolutely revolutionizes multiple autoimmune diseases. Pain that traverses down the back. There can be shooting pain that goes into the arms and legs. There are many other manifestations of it as well. There can be paroxysmal feelings of constriction across the thorax or abdomen, a banding-like sensation. There can be sensitivity to touch and other phenomena such as temperature changes causing pain and triggering pain. So quite a few different manifestations of pain. It's not all in the back. It's not all between the shoulders. It can be in the arms and legs. And again, all somatosensation and below the neck, comes into the spinal, or actually below the face comes into the spinal cord, right? The somatosensation of the face goes directly into the brain, but everything else from your scalp on down runs through the spinal cord. And you can get pain from the optic nerve as well. This is another structure that, when inflamed, can cause quite a bit of pain. Many patients who experience optic neuritis can experience pain with eye movement or pain behind the eye. So that's also a common manifestation. Now, that tends to improve following resolution of the clinical attack. I see far more patients experiencing chronic neuropathic pain that's somatic, meaning involving the body, rather than retrobulbar. Most of my patients who have had optic neuritis and have improved have resolution of the eye pain with treatment with corticosteroids. So most of the chronic pain we deal with, I think, is related to spinal cord damage, but there may be other structures within the brain that can be affected in NMO as well that may regulate pain. Quality of life is, of course, very important. This is what patients experience, and it is one of those things that it's harder to assess in a meaningful manner. We have a variety of tools that can be quite helpful, which are patient-reported outcomes. And I think everybody recognizes that these are important, but very few people know how to use them and demonstrate in a practical way their meaning. And this is challenging. So certain phenomena that patients experience are entirely subjective. So, for example, everybody has experienced pain. We all know what pain is, but it is purely subjective. It's something that you as a person feel and experience, and you can report it and describe it, and you can, give it a scale of 1 to 10 in severity and all these other things, but it's purely subjective. You have no way, there is currently no way to measure somebody else's pain other than to ask them, how does it feel? And so there's a gap in terms of objective assessments. If somebody experiences worsening disability, we have disability scales. If they experience a relapse, we have ways of, or an attack in NMO, we have ways of understanding those phenomena, documenting them, confirming them objectively. But other phenomena are very, very hard to pin down objectively, and pain is one of those areas. And not surprisingly, in neuromyelitis optica, pain is a prominent manifestation of this disease. Why? Well, because of spinal cord injury. And of course, the spinal cord is a critical structure that is involved in somatosensation throughout the body. And when the spinal cord can be damaged, you can get chronic pain syndromes emerging very commonly, not only in neuromyelitis optica, but other conditions as well. But the extent of pain in NMO has always been a bit disproportionate. It's been one of those things that's been hard to understand. Many NMO patients experience tremendous amount of pain, and we have to use medications to help suppress the neuropathic pain they experience. Why they experience so much pain is not known. It's presumed to be related to inflammation, but I think that's an oversimplistic way to think about things, because we have seen that many NMO patients experience severe, excruciating pain coming from the spinal cord, independent of disease activity, meaning even when they're not having an attack, they can be in a lot of pain. And we don't know exactly why that's the case. So this was a topic that we were particularly interested in, and we had previously reported in the N Momentum study that following treatment with inebilizumab, patients' pain improved over time. And so the supposition was that this was somehow linked to a suppression of disease activity in NMO. And that's a reasonable supposition. But what we wanted to understand was in patients who hadn't had an attack, would a treatment with inebilizumab be associated with a decline in pain? So in these study participants who were clinically stable before entering in the study, and they hadn't had an attack in the last 6 months, we wanted to know, in those individuals who were experiencing baseline pain, first off, did that experience of baseline pain correlate with disability? And sure enough, it did. And second, we wanted to know, following treatment in those relatively stable patients, would inebilizumab treatment be associated with a decline in pain? And that was the hypothesis that we were testing in this post-hoc analysis. And actually, to my surprise, we found a decline in pain. And this was something I was not expecting at all. I thought pain was driven by attacks, and in these patients who hadn't had a recent attack and were clinically stable, that their pain would just be the same, that we wouldn't see a decline in pain. But in fact, we saw a clinically significant and statistically significant decline in pain scores over time. Now, when you think about that for a moment, it's kind of perplexing, right? Why would depleting B cells result in any effect on somebody's chronic pain? And B cells aren't cells that cause pain. They're cells of the immune system that have many different functions, but causing pain is not really one of their roles. And so how do you get a decline in pain following B cell depletion? And why is it that this was only seen with inebilizumab? Why haven't we seen it with other products such as complement inhibitors or interleukin-6 receptor blockers, or even the older immune suppressants? Why is it that we haven't seen a decline in pain in relatively stable patients treated with these other agents? And some of these other agents are incredibly effective. Satralizumab is extremely effective, as is eculizumab and ravulizumab. These are all highly effective therapies that block attacks. Why is it that we don't see a robust effect in pain with these agents as well? So we don't know the answer to this, of course. We don't fully understand the substrate and the biological basis of neuropathic pain in general, and we don't understand that basis in NMO. But nonetheless, I think there's an important learning point here. Pain in NMO is not simply due to attacks. It's not due to disease activity. There is pain in NMO, which is likely due to ongoing immunological effects. And some of those immunological effects are attack related, but there are likely other immunological effects of living with NMO that we don't measure simply by looking at attacks. And I think that when you deplete B cells, you are changing a regulation in the immune milieu of the adaptive immune system, not just through the direct effect on B cells, but indirect effects on T cells and natural killer cells and other cells as well. And as a consequence of altering that immune milieu, we see a decline in pain. And I think that's really the only plausible explanation for why this effect seems to be seen exclusively with inebilizumab and not the other therapies. The other therapies are highly targeted. So interleukin-6 receptor blockade targets one very important pro-inflammatory cytokine, interleukin-6, and helps shut down disease activity. But it hasn't been consistently shown to decrease pain in NMO patients. And similarly, with complement inhibition, you can completely block attacks. Ravulizumab purports 100% efficacy with attack blockade, but we don't see robust results with either eculizumab or ravulizumab in decreasing pain. Maybe those studies haven't been done yet and are remaining to be illustrated, but it is also possible that complement blockade, as being that terminal last step in causing new acute inflammatory injury, only blocks one type of ongoing neuroinflammation in NMO, and there's probably other aspects of neuroinflammation that are active and not addressed either by complement inhibition or interleukin-6 receptor blockade. Reality is always more complicated than our simple models. The simpler model you start off with, you get really, it's a good place to begin, but it won't explain everything. And I think this is one of these aspects of NMO, which is so interesting. The tools we have now today to interrogate neuromyelitis optica are very impressive. The therapies that we have are fantastic, but there's still more that we need to learn and understand about how the immune system interacts with the central nervous system to not only cause clinical attacks in NMO, but also cause some of the ongoing perplexing and vexing symptoms associated with NMO, such as chronic neuropathic pain. I think there are a couple key points. So first off, neuromyelitis optica has emerged from a period of time of great darkness where we had no useful therapeutic interventions into an era where we have now multiple therapies that are highly effective for treatment of NMO. It's absolutely essential that physicians who see these patients know about this. And so therefore, in order to diagnose neuromyelitis optica correctly, people need to know about the diagnostic test, when to order it, and in whom to order the test. I would say anybody presenting with optic neuritis or myelitis or intractable nausea and vomiting that is of unclear etiology should have an aquaporin 4 cell-based antibody test performed. And it's very important that people understand the difference between the cell-based assay and the ELISA assay. The ELISA assay is not cell-based. It's a less expensive test, but it's not nearly as good. It's prone to false negatives and false positives. And so for proper diagnosis, you really need to use the cell-based assay, which is generally available. It's available through organizations such as Quest and others, ARUP and LabCorp, as well as the Mayo Clinic. So this is a diagnostically available study. Physicians need to know when to order the study. That includes ER physicians who are likely to see patients with optic neuritis and myelitis and intractable nausea and vomiting. So the quicker we're able to make the diagnosis and connect a patient with a specialist who can appropriately treat that patient, the better outcomes we're going to have for our patients overall.